Hi, my name's Ken Pecoraro. I've been at CPC Behavioral Healthcare for 18 years, and I started back in 2001. And one of the things that uh, drew me to working at CPC is that it was a harm reduction agency, even back in 2001, when a lot of agencies were still abstinence based. And I got a lot of experience working in a harm reduction environment. And I wanted to cover 2 points that kind of really can help people to understand harm reduction in its simplest form, just some basic principles, and consider it like harm reduction simplified. And those two points are: harm reduction is about one, starting where the person is. That's the first principle. And two is accepting incremental change. So let's go through those real quick. Let's start with starting where the person is. A great quote from Arthur Ashe is: start where you are, use what you have, do what you can. People enter treatment at different stages, and to just expect someone to enter treatment and to be where you want them to be as the counselor is unrealistic. Back in the old days when everything was abstinence based, it was a very expert based philosophy. So the counselor looked at the client as if they were saying, I'm the expert. Here's what you need to do. I can tell you all the things to do, and you follow my lead, and I will lead you to abstinence. And certain clients were able to do it, but many weren't. And back then, with this expert based my way or the highway type of philosophy, a lot of the clients ended up taking the highway because they weren't able to achieve abstinence. It's no different today. Not everybody is ready for abstinence. In fact, the vast majority of people aren't. So, being more realistic about it, starting where the person is, it's important for the clinician to take the person's strengths and the obstacles they face, their individual circumstances, as well as the person's preferences, and work with the person from there and allow that to dictate the way treatment goes, being client-centered or person-centered. And a great example that can help put that in perspective would be, imagine if you had a big truck filled with stuff to unload, and a group of workers came out there, and you had them unload the truck for you, but you noticed one person was in a wheelchair, and you notice that person's doing the best they can, but they're lagging behind because they have an added obstacle. Would it be fair to say to that person, hey, why are you lagging behind everyone? Why aren't you carrying as much as everyone? Would it be fair to expect that person with a more challenging situation to do as much and to carry as much of a load as everybody else? Of course it wouldn't. You base your expectations on where people are at. And the same is true with someone with a substance use issue. About at least 2/3 of the time, people that enter treatment for substance use usually have a co-occurring mental health disorder. So you have to take into consideration where people are at. People that enter treatment are usually doing it under very difficult circumstances. So to have all these expectations about what you as the counselor thinks that person is able and ready to do is not realistic. Starting where the person is at is what's realistic. Somebody's making a statement. You hear family members say things like this all the time. Well, I'm in recovery from alcohol. Why can't my son just stop using heroin? And it doesn't work like that. It's not apples to apples. Everybody's situation is different. It's based on empathy, trying to understand where people are coming from, starting where the person is, based on their strengths, their obstacles, their circumstances, and their motivation level, and even their preferences. Okay, so that's the first principle. The second one is, even more important, accepting incremental change. Harm reduction is about change the way people really do change, little by little. You hear stories about someone, deciding they want to stop whatever behavior, and boom, they change and everything works out and they live happily ever after. Those are maybe get the headlines, but that's not really how it usually works. And an example that can help you conceptualize that is, imagine you go to the doctor and you think everything's Okay, and the doctor says, your tests are a little off here. You're on the verge of developing a chronic illness. Let's say that chronic illness is diabetes, for example. So the doctor says, you don't want to get diabetes. Here, I'm going to give you this list of stuff to do. I want you to lose this many pounds. I want you to stop eating all these bad foods. He writes them down for you. He wants you to start eating all these good foods, salads and kale and all this stuff. He says, I want you to exercise this many times a week and take these vitamins. You know what? Take this medication too if the vitamins don't work. And I want you to go on the diabetes website and read all this information. And he writes it all out for you and he puts it on a list. And you leave the office and you say, you know what? I don't want to come down with diabetes and have this chronic situation. So I'm going to do everything on this list to prevent myself from from progressing. A week later, how many of those things on the list do you think the average person is doing? So let's say the list has 20 things. Maybe 2 or 3, maybe 4, maybe a real go-getter is doing 5, 6. But the point is, people change as they're ready. It's hard to just take a whole list of things to do and boom and do everything and follow everything by the book and be a Superman and make all the changes that you need to make. Comparing that to substance use, putting that in perspective, imagine that someone comes into treatment. Again, they're usually struggling with a co-occurring mental illness as well, and if they're in treatment, there's usually all kinds of other circumstances going on, difficulties, because drug use does tend to put people in difficult situations, especially by the time they make it to treatment. And a counselor says, okay, to this guy enters treatment, and the counselor says, all right, I want you to stop using all substances immediately. I want you to be abstinent and stay that way right away. No relapsing. I want you to find new ways to cope. Here, I'm going to give you a whole list of things to do to start coping. Take away what the drug used to be everything for you. Now I want you to do all these new things, starting right away. And by the way, I want you to change all your friends. Get rid of all your friends. Get new ones. And I want you to come to this program for 9 hours a week or 12 hours a week. I want you to take these medications. I want you to start being spiritual and believe in a higher power and pray and do yoga and all these other things and meditate. I want you to go to meetings, 90 meetings in 90 days, in addition to coming to the treatment program. And I'm going to teach you all these skills, assertiveness and managing your emotions and doing all these things with no longer having the drug use to help you through. And I want you to find a whole bunch of new ways to have fun without using drugs and get a job while you're at it. So you see the list goes on and on. Do you see the difficulty here? We're asking a person to giving them this long laundry list to do. Is it realistic to expect the person is just going to follow everything on the list and live happily ever after? No. People change little by little. And we have ideals that we put before people that we want, to work towards getting better, using less, working towards abstinence, working on getting better. But people do it little by little, realistically speaking. So that's just 2 quick points to really help you understand harm reduction. And that's starting where the person is, being person-centered, taking into account that person's unique situation and letting that guide treatment. And 2, accepting incremental change. Accepting change for how it is. People change at their own pace, little by little. And that's the kind of change that lasts.